Yep, you're good, Andrew.
We're good. Okay. All right. So the title of my presentation is A Common Condition and Uncommon Cause. And we'll see why here as we get into it. Let's go to the next slide here. And so this case study, the patient first got into the hospital. They were unrelated by their granddaughter and was not breathing and no heartbeat. Was able to actually revive them in the ambulance, fortunately, so she wasn't out very long. And they ultimately did have to put her on a ventilator, and they did get her stabilized after a few hours. But she was in a coma, probably because she's on a ventilator. She was on max doses of various pressors like epinephrine, lefophed, and vasopressin, and also a bicarb drip in the ER. So all this takes place in the ER, and you'll see why that's important soon. So obviously this is a big deal. You need to find out what's going on with them very quickly because time's of the essence. The longer you're on a ventilator, the longer you're not breathing or on your own is it just lowers the mortality, lowers your chances basically. So the physical exam showed no major injuries or anything obvious, head injuries. The patient does suffer from COPD and lung cancer, so we did have some record of her. The lung cancer was being treated at another facility, so we're not entirely sure what medications or anything she was on, but she does have COPD and lung cancer and many other comorbidities as well. I believe also diabetes. They did a head CT on her for hemorrhage. It was negative. Her abdominal X-ray was normal, but her chest X-ray, as much as they could see, for because she's on a ventilator, they were able to see signs of a pleural effusion. If you look at the right side here, you can see that's a an example of a minor pleural effusion, and the one on the left is a little more pronounced. I believe it was considered slight at the time, but they put a lot of on the imaging because they just weren't able to get great pictures. The cardiac enzymes were normal, so this is not like your standard heart attack. This is something else. Her blood pressure was also extremely low, and her CMP and other basic studies when you get into shows she was in renal failure and also metabolic acidosis. So she's not doing well. So obviously some kind of answer for treatment needed to be found fast. And when you get these kind of sets of symptoms, sepsis is really the first thing they're looking for, and also the most acute thing that they need to kind of solve right away. So because of the pleural, the chest X-ray and the suspecting for sepsis, they did blood cultures in a sputum specimen. The sputum gram stain was a good one, and they did find a significant amount of gram-negative rods. Still hadn't decided if that's relevant yet, so we're still collecting data. The patient also appears to be immunocompromised. Their WBC was 1.33, which is low, and just shows kind of the standard pattern for somebody on chemotherapy or radiation therapy. Almost all lymphocytes, if I recall. When we used to do those in hematology, that was kind of the standard pattern. When they get that low, it's all it is lymphocytes and not really a standard infection response. So this person definitely appeared to be immunocompromised in some way, shape, or form. They did start her on IV vancomycin on the patient in the ER, and the reason they do that instead of waiting to find out what organism it is because a lot of times with vancomycin they suspect a MRSA. If sepsis, it might be MRSA. So they just start them on therapy for that, and then until they have more information, and then they can adjust because vancomycin's a pretty strong antibiotic. Unfortunately, the next morning she went into cardiac arrest again and was not able to be revived. So unfortunately, this is not a happy ending, but it is instructive though what it actually ended up being. And she was pronounced deceased by doctors in the ER the next morning before we were even able to decide, what organism it was. So a few hours after her passing, both of her blood culture bottles were signaled positive by the BACTEC analyzer, and the bottles were plated and evaluated the next day on the bench. So, unfortunately, with the timing is just, it's just, you need an answer fast, and sometimes it's just not fast enough. So here was the gram stain, or an example of the gram stain. This is a little thicker than a normal one would be, but this is like, and you make a guess on what kind of these. Are these gram negative rods, or these gram negative cocci? And that, that was kind of a question on the bench here. Multiple techs looked at it and looked at the various here, and did have trouble determining that. I think they decided to gram negative rods. All right, the culture plates. So, obviously the patient had passed, but that still doesn't mean we stop. So the plates had growth of pretty nondescript, non-hemolytic gray colonies on the blood agar plates. And you can see here on the right, this is an example. This is what they looked like. They had non-hemolytic, just kind of your standard nondescript colonies. There was no growth on the McConkey, despite it being staining gram negative. The catalase, the indole, and the oxidase were both positive. The gram stain of the colonies themselves on the plate were confirmed to be a gram negative coccobacilli. And so we went from gram negative rods to that, but still, it can vary. The sputum culture also shows the same organism growing with the same biochemicals. So it's possible that these are related. And this is probably the time to guess if anybody's really on their game here, if they know what the organism is. Does anybody have a guess? I can open it up to somebody wanting the peak.
Possibly Pastorella.
Pastorella.
All right, yeah. And I think we have a winner here. Yep, Pastorella multocida, or multocida. I always mispronounce that. Pastorella multocida is a gram negative coccobacilli. That is yeah, you gotta, I tried to put a hint in the beginning if you saw the dog and the cat in the front there. The Pastorella multocida is a gram negative coccobacilli that is a normal flora in all kinds of animals, including us. 70 to 90% of dogs and 20 to 50% of cats have this organism as part of their normal flora, but cows, rabbits, birds even, this can cause something called fowl cholera. So it's also a pathogen in other animals and not just normal flora. So humans can also have this as part of their normal flora. As a pathogen in humans, it's most commonly associated and isolated from dog and cat bites or licks, if they lick one of your open wounds. And it's usually not a big deal for most people. It can range from a superficial skin infection and all the way to severe sepsis, as we're kind of seeing in this case study here. And sepsis from this organism is very deadly and has a very high mortality rate of 31%. And I think one of the key identifying factors, that kind of lets you kind of suspect this right away, is that it did not grow in McConkey agar at all, despite being gram negative. All right, so clinical manifestations and treatment. So the most common way you see this is a mild cellulitis following animal bites, scratches, licks, just some kind of close contact with an animal. However, that's not the only way you can get it. That's just the most common. It also is responsible for respiratory infections, usually in with a high comorbidity with COPD or other very serious lung disease. This patient had lung cancer and also COPD, so she's kind of a prime suspect for something like this. But other conditions, meningitis, bacteremia, which is what ended up happening here, endocarditis, abdominal infections, they've all been reported from this organism. And people who are seriously ill, I think it was 80% of them all had a major comorbidity, diabetes, lung cancer, like other malignancies, lung issues, anything that kind of lowers your immune system is gonna make this organism from a minor problem to a major problem. And animal vectors are not always involved. even though that's usually should be your first suspect. Like I said, it can be inside you as an opportunistic pathogen. And the treatment for this, because when you have a scratch or a bite, the animal's mouth is dirty, so it's usually a polymicrobial infection. And so amoxicillin is usually kind of the first line of treatment. And penicillin G is usually the first drug of choice for monomicrobial infection. So if we had found out faster, they probably would have started her out on a penicillin here to take care of that, because it is a monomicrobial infection. They didn't find any evidence of a significant other organisms. Sometimes these can be beta-lactamase producing, so ampicillin is an alternative if penicillin's not indicated, or if they're allergic to penicillin, which many people are. So in conclusion, the patient, so you're probably wondering, well, where did she get this from? So the patient's skin was actually evaluated several times during their stay. Just, multiple eyes looking at it, and there were no scratches, no significant skin infections, nothing to indicate that she had been bitten by an animal or scratched by an animal. But the sputum specimen was positive for the same organism. It did end up being Pasteurella as well. So the respiratory, so that implies that there's a respiratory portal of entry. And that is uncommon, but it is certainly possible. And she could have been too close to animals. They did not say whether or not she had animals in her notes, but she did have children, and I know kids love pets and things like that. So it's very possible somebody brought a dog over. And if this woman kept pets herself, she has a very weakened immune and respiratory system due to her comorbidities, COPD, malignancy, and her lung cancer. It left her very vulnerable to acquire opportunistic pathogen like this, and left untreated, it can lead to sepsis and death, as you can see in this thing here. So and vancomycin was administered, but unfortunately it was just too late. All right, so does anybody have any questions? I know they said they wanted a couple minutes for questions here.
Thank you. That was a great presentation. My question is more along the lines of suspicion. So were at any point, the physicians, infectious disease, suspicious specifically for anything having to do with pets or Pasteurella in particular?
That's a great question. Unfortunately, she came into the ER unresponsive in the late afternoon, and she passed early the next morning. So it's like there really wasn't time. They were just able barely to stabilize her before they were able to investigate something like that. And I'm sure if they had more time, if if she's been there a week, they definitely would be able to decide something like that. But usually they start to suspect this, and other case studies reviewed, they have a big bite on their arm, or a bunch of scratches on their legs that just don't look good. And you're right, that would definitely be, if you suspect an animal infection, from a bite or scratch, that's usually one of the first organisms you would be looking for.
Thank you.
You're welcome.
Yeah, this is Jane Hada. That was a great presentation. I just want to make a comment along that line. My sister-in-law actually had a cellulitis due to Pasteurella that she got when she tangled with a squirrel. So it's important to think beyond dogs and cats and think about those other animals as well.
Yeah, birds are another big one that you probably wouldn't think. And they have it actually as a pathogen. They get kind of something called fowl cholera. But yeah, almost any mammal can carry this.
So I had a question about susceptibility testing. So at UF, what's your typical practice for when it's like a blood culture or sterile body fluid? Do you guys do any susceptibility testing in-house, or is it just upon request? Or
well, for Pasteurella, I don't believe they do susceptibility testing on that, because there is a pretty established thing, and we did not do susceptibility testing on this because because the patient passed by the time, but we did identify the organism. But like amoxicillin is the first one. If it's a bite, penicillin is just kind of your standard one, and then they probably would evaluate it for beta lactamase production. So if that was the case, then ampicillin would be your go-to.
Thank you.
Thank you. Any other questions for Andrew? Great presentation, Andrew. Thank you.
All right, thank you guys so much for having me, and I'll probably sit in for the rest of these too.
Oh yeah,
excited.
yeah. Please do, please do. Our next speaker is Kyle McGee. He's a medical technologist in the clinical micro department at Mayo Clinic and is an instructor of laboratory medicine or College of Medicine. Kyle is also an adjunct professor of medical laboratory technology at Florida State College at Jacksonville. We're pleased to have him presenting on an unusual microbacterium in an IV drug user. So welcome, Kyle.
Awesome. Thanks, everybody. Thanks, Gary, for the introduction. And thank you to the Jacksonville Area Microbiology Society for having me today. And let's see here. This is my first Zoom meeting, so please let me out. I'm going to try screen sharing.
I'm looking. Oh, there you are. I'll give you a host.
All right. Thank you. Can everybody hear me okay?
Yes, you're coming through good.
I think I need host back. Claim host. All right, Kyle, here it comes. There you go, sir.
Awesome. Thank you. Let's see here. Can people see my screen?
Yes.
Can you see my PowerPoint?
Yes.
Yes.
Awesome. Perfect.
There you go.
All right, sweet. So as the title states, an unusual microbacteria in a drug user. I kind of realized in retrospect, I kind of geared my PowerPoint towards like keeping this a secret and keeping you guys guessing in terms of what was causing the issue. And then here my title is just giving it away that it's a microbacteria. But anyways, forward and onward, I digress. Here's my email if you guys have any questions after the fact. And we'll start with the patient presentation. So the patient was a 30-year-old male. He presents to the ED today after a post-cardiac arrest. He was found unresponsive in his home. He had a suspected heroin overdose. The EMS found the patient in a systole, and on the scene, the patient was given multiple rounds of epinephrine, sodium bicarbonate. He was even intubated in the field, and prior to the EMS arrival, he was given CPR by a bystander. Oh. Why won't? There we go. So right off the bat, in terms of laboratory tests and antibiotics, they drew 2 sets of blood cultures, and the patient was also put on broad spectrum antibiotics to account for any potential infection that there may be. We had 1 set, and in that set, 1 aerobic bottle came positive. It came positive, well, it was drawn on 4/5, and it came positive 5 days later on 4/10. And so the initial gram stain, right off the bat, the gram stain is showing beaded rods of some sort. Our initial impression was maybe it was branching beaded rods, maybe potentially a nocardia. But following procedure, we did a Kenyan as well as a modified Kenyan stain. And so this is where things get kind of weird. The Kenyan stain on the left looks like it's trying to be positive, or at least it wants to be, but I had to blow up the picture because it was so faintly staining. And for the most part, a lot of the smear stained blue. These were the best pictures I could find. Whereas if you look at the modified Kenyan stain, you can see individual bacilli staining bright, cherry red, partially acid fast. And it's not even really fitting the bill of something that would be nocardia because it's not branching. They're just little tiny individual bacilli. Honestly, I thought the Kenyan would look more like what the modified looks like, but it seems like things are kind of reversed in this particular instance. And so we kept reading the Kenyan stain because we weren't sure whether it was acid fast or partially acid fast. And we found one area on the Kenyan stain where it was staining acid fast. And, I blew it up here, but you can see the individual bacilli and you can see them picking up that carbofusion. And so the next day we started getting some good aerobic culture growth on our routine media for the blood cultures. Routine media for blood cultures at Mayo Clinic is blood, chocolate, a conky, as well as your anaerobic blood agar. By day 3, we had very robust growth, very wet colonies, as you can see right there. They're glistening in the light. Same story as the chocolate agar. Day 3, very robust growth, wet colonies as well. And then we had also made a 7H11 sub after the culture came off. And we only had growth on the non-selective side of the biplate. At Mayo Clinic, we use the 7H11 media and we use a biplate form. So one side is non-selective and the other side is more selective for your acid-fast bacilli. In this particular instance, it only grew on the non-selective side. So at this point, I was kind of freaking out, like, if the initial call was the correct call with it being acid fast, I thought maybe after seeing the culture growth that it could potentially be partially acid fast, or it could even be some kind of just weird bacteria that so happens to pick up carbofusion on a partially acid fast spectrum. And so I did some more stains from the plates, and of course the Kenyan stain was weird. Negative, positive. The majority of the stain was staining methylene blue rods. You would find the occasional area, as you can see on the picture on the right, that is showing a clump of rods that appear to be picking up the carbofusion. Pretty similar story to what we were seeing on the initial Kenyan stain from the actual blood culture. So then we proceeded with a modified Kenyan from the plates, and of course, it was beautiful. It was raging positive, cherry red rods everywhere you look. And then we did the Graham stain. Graham stain from the plates was a little bit of a different story. You can see some purple speckles of beaded rods here and there in this picture. And then the majority of them appear to be maybe Gram negative, maybe Gram positive. So up to this point, I was wondering, like, if this was even partially acid fast, if it was more bacterial in nature. I had read reports that Corynebacterium can potentially pick up carbofusion and mislead people. So it's kind of really throwing me for a loop. We stuck to our guns though, and we ended up sending the isolate out to Mayo Clinic Rochester for the 16S genetic sequencing. And the identification came back as Microbacteria and Microgenicum. So all was well. Our initial call was good, but it left me with a lot of questions because up to this point in my 6 years of experience, I've never seen something stain partially acid fast, but not Kenyan positive, or at least not Kenyan positive to what I'm used to seeing Kenyan positive. So a little bit about Microgenicum. It was previously identified as a Chelone-like organism, largely considered non-pathogenic, but it has been associated in the past with waterborne nosocomial infections. It's very ubiquitous in water supplies. So your tap water, your hospital water, and your dental unit water lines. And typically in those lines, they exist in biofilms. It's kind of what they're known for. They're great at creating biofilms and resisting routine water treatments. So the biofilms contribute to their hardiness, and there's speculation that they have a symbiotic relationship with some protozoans such as Acanthamoeba, polyphagia. It's believed that when things get tough and things get extreme, the microbacteria will actually find safe haven within this Acanthamoeba. And that's what allows it to tolerate disinfectants and chlorination and extreme temperatures. And so this particular species is almost always identified as a pathogen in many cases of bacterial sepsis in both your healthy individuals as well as your immunocompromised individuals. Many of the cases being associated with your intravenous catheters. So as I stated in the beginning, the patient was an IV drug user. So I'm guessing that this particular case of sepsis is probably due to that. And so the big question I had was, why the negative Kenyan stain, or at least the, majority of the Kenyan stain being negative and just one spot of positive rods. And so kind of a little background on your microbacteria and their cell walls. I mean, we all know that they have complex lipids, the peptidoglycan layer, as well as, the mycolic acids, and that creates a hydrophobic effect. So a lot of our routine stains don't really work on microbacteria, and they're also resistant to acid alcohol, hence the name acid-fast bacilli. And so the only information I could really find on it, so mucogenicum falls into the group of your rapid growing microbacteria, which is obvious because it grew in 5 days within the blood culture. And there's a lot of articles out there that say a lot of your acid fastness can be lost during various stages of growth, as well as long-term antimicrobial treatment. So it would be my guess that when the blood culture came off the machine, it must have been in that weird phase of growth to where it didn't have that acid fast wall. And that's why we were getting such weird reactions, because mycolic acids in that cell wall weren't as built up as what you would normally see in a microbacterial culture when you're doing your routine Kenyans. And the picture that I had right there in the bottom is just kind of reiterating the point that typically your microbacteria, when staining with carbofusion, they're staining, cherry red, pink, and then anything else that isn't going to pick up that carbofusion because of this mycolic acid cell wall and all of that good stuff is going to stain methylene blue, which is your counter stain. And so that got me wondering, if this was the norm for this particular species, if other laboratories had run into this situation where, the Kenyan was negative, the partially acid fast stain was beautiful positive, and the gram stain was, beaded or just kind of funky in general. And pretty quickly, I found a similar case with a better title, a confusing, unexpected, and mistaken case of bacteremia. And right there in the article, they ran into a similar situation, and I've blown up at the bottom a little excerpt from it where it says, it may appear to be Kenyan negative and partially acid fast, leading to a potential misidentification as a Nocardia species, as happened in this case. So in this particular case, they actually called it Nocardia. And then once they sent it out for genetic sequencing, they found out it was Mucogenicum. It also mentions that a lot of times people mistake it for gram-positive bacilli or dipteroid in nature, which we kind of saw on the gram stain from the pure growth plates, that it was kind of sort of picking up the gram stain. So a lot to be on top of there. So as far as treatment goes, it's fairly susceptible to a lot of your routine antimicrobial agents. There is some resistance to your primary antimycobacterial drugs like rifampin, but for the most part, it's pretty susceptible. So in conclusion, always perform both a modified Kenyan and a Kenyan stain when suspicious of either acid-fast bacilli or partially acid-fast bacilli. I feel like it's really easy, especially for newer techs, to see a gram stain from that blood culture that looks like that and think, oh, this is exactly what I learned in my class. Like these are beaded gram-positive branching rods. I'm going to do a modified, and then get that beautiful modified Kenyan and just call it a day and call it, partially acid fast resembling Nocardia. So it's important that you do both those stains, because a lot of your microbacteria will still stain partially acid fast. So make sure whenever you're, suspecting Nocardia to follow up with the Kenyan stain as well as your modified Kenyan. Mycobacterium mucogenicum is a ubiquitous organism. It's found in many water sources all throughout, and that's due because of its biofilm that lets it resist a lot of sanitization treatments. And then also the organism is especially associated with catheter-related sepsis. And then lastly, it can appear kidney negative and partially acid fast, leading to a potential misidentification of Nocardia species. Here are my references. And do we have any questions? Oh,
And everybody check your mute.
Oh, I just want to say good job, Kyle.
what was that?
Just a great job. It was good.
Oh, thanks, buddy.
Excellent presentation, Kyle.
Thank you.
With mycobacteria in general, would you say that you typically will identify, like if it's found in the, I guess depending on the source, will you go more in depth depending on the source and depending on what type of subspecies it is, as far as going further with susceptibility testing, or do you go just based on the specimen type versus the actual just identification of the organism? Just curious as to what your practices are.
So at Mayo Clinic, really the only Microbacteria species that comes into question in terms of like contaminant and whether or not it gets sensitivities is going to be Microbacteria gordoniae. That particular species, we have to call the physician, educate them that, typically this is contaminant. Do you suspect infection? Would you like sensitivities? So a lot of times they say yes, a lot of times they say no. But that's the only species that I'm aware of at our institution that we follow up with the physician for sensitivities. This particular species in general, it was the mindset with it that it was treated a lot like Microbacteria gordoniae in terms of a lot of people thought it was just contaminant because it was so ubiquitous in water. A lot of times it was disregarded. I brought this case forward because it's becoming more and more obvious that this is a pathogen and could be a real issue, especially when it comes to sepsis. Does that answer your question?
Yes, it does. Thank you.
Any other questions?
Yeah. Any other questions for Kyle? Okay, well, thank you, Kyle.
Yeah, thank you.
Thank you. Well, moving on to our last but not least final presentation. It's a team presentation, and welcome Francis to introduce them, please.
Yes, of course. First we have Aaron Odegaard. He received his master's degree in biomedical science and molecular pharmacology and experimental therapeutics from Mayo Graduate School of Biomedical Sciences. And Mr. Odegaard is passionate about medical laboratory science. I can tell you that. He serves as the chair of the ASCP Council of Laboratory Professionals and on the ASCP Board of Directors. So he's busy in and out of the laboratory. Jennifer Tedrick is also ASCP certified, and she actually began her career as a nuclear propulsion plant operator. So beware, she is fierce. But she saw the light and went into medical lab science. She's been an adjunct instructor and technologist in South Carolina. And then she came on over to Jacksonville and found her way to Baptist. Both Aaron and Jennifer are just really passionate about learning and teaching and have demonstrated this through their daily involvement in just investigating and sharing what they learn with other technologists in the laboratory. So without further ado, Aaron and Jennifer.
But we had a little bit of a technical thing. So just one sec.
We hear you and we can see your slide.
Yeah.
All right, I'm just looking for the chat box. Oh, there it is. Okay, perfect. Okay, so here we go. Hi, my name is Aaron Odegaard, and this is my co-host.
I'm Jennifer Kedrick.
Yep, and we'll be leading you guys through a case of A Pair Leads to Trouble, a tale of sepsis.
Hey, Aaron.
Yep.
Adjust your camera a little bit higher or next to Jennifer.
Yeah, we got a
Yeah, we
little
have
bit of a
height
height.
There
thing
you
going
go.
on.
She won't bite. You can sit next to her.
There we go. Okay, so our disclosures, these are our own views for the program. They don't represent anything from Baptist. No professional advice should come from this. We are not the PhD. And
And we have no conflict of interest in relation to this program.
okay. We're going to start in. Here's our roadmap. We're going to emphasize the role of the laboratory in diagnosis.
We're going to discuss the specific laboratory testing and detection challenges.
Okay, and then finally, we're going to review just a little bit about growing resistance and the surveillance programs. So to jump right in, for our clinical presentation, we have our patient's a 32-year-old male that works as a butcher. He visited one of our satellite hospitals on the February 4th and on April 7th, presenting to the ER with left shoulder pain and intermittent chest pain. So part of the protocol is to actually go ahead and rule out any kind of cardiac involvement. That was actually ruled out. Imaging was done, and they weren't really seeing anything. So they ended up sending him home, saying he just rested and used over-the-counter medications. He returned later on 4/16 to still one of our remote hospitals, and was complaining of the same shoulder pain. It was radiating. So at this point, they decided to consult with orthopedics and do rule-outs for cardiac involvement again and pulmonary embolisms, and then asked him to kind of follow up with his physician. So then, and actually say that if on the 18th, or if anything happened, to come back again. So on the 18th, he came back to the ER with more severe shoulder pain, and now it's kind of spread to his lower legs bilaterally. So at this point, the team decided to go ahead and admit him and to actually transfer him down to our main campus at Baptist downtown. So his previous medical history, he had uncontrolled to somewhat controlled hypertension. He's a borderline diabetic, has GERD, and has no history of cardiac issues, blurred vision, headaches, or specific injury or trauma. So some initial results on the 16th. They did do a complete blood count and did notice that he had an elevated white count of 18. And in the breakdown, noticed that 86% was showing up as neutrophils, and that he also had an elevated C-reactive protein with an elevated D-dimer and decreased MCV and MCH. So they did draw blood cultures on the 16th. So one of the positives came up positive, the aerobic bottle, and just to show that there was no cardiac involvement, or the radiology imaging showed no significant findings. So with the positive, our evening shift tech did see the gram stain that I'm showing you. So we're kind of at a standstill. They look kind of a little gram negative, but they look like they're clustering or in chains. So that puts them in a tough spot of, okay, is this overly colorized GPC in clusters, or gram-negative diplococci? So this is where the part of the presentation we're going to ask you guys to participate a little bit and kind of give your impression of whether you think it's overly colorized GPC or gram-negative diplococci. So we'll give you guys a second to put your guesses in the chat box. I see my friend Elizabeth Dominguez on, so come on, Elizabeth. Okay, no, oh, okay, we have some brave people. Thank you. Thank you, Mary. Okay. Okay, and we're going to close it out in 3, 2, 1. Okay, so another reason why this is a tough call is if you're going with potentially gram-negative diplococci, that directs the team to possibly think Neisseria meningitis, which involves infection control and all sorts of other measures. So it makes it a real tough call. So we're going to reveal what actually happened. Jen's going to walk us through more of the labs.
Okay, so on the 17th, the positive bottle, it was called as gram-positive cocci in pairs and clusters. Then on the 18th, you know, the CBC still just a little bit elevated, and the CRP and the ESR are elevated. So repeat blood cultures were collected, and then 1 out of 4 became positive, aerobic bottle. And then on the 19th, the bottle popped as positive, and then you know, it took 3 people to come up with this gram-negative diplococci. You know, we're on first shift, so you know, we had again 3 people to review this gram stain, and then also the plates from the previous positive we were able to go back and look at and see if this made sense to us.
I get to walk us through. So initially, the culture plates that we're actually seeing, we're seeing these small glistening raised colonies. You can kind of see here. It's growing both on the blood and the chocolate at about 48. So with our initial culture workup, we are starting out, we've got our gray colonies on our blood plate. So one of the first biochemicals we're going to do is this oxidase right here. So if anyone's willing to tell me whether they think it's positive or negative. Beautiful. Thank you, Beth. Okay, so it's positive. So we have a positive oxidase. Our catalase is positive, that you can see there. And then this is the gram stain directly from our plate. And you can kind of see these nice little gram-negative diplococci. So a nice culture reminder too is that this is a capnophilic organism. So when you're not working with it, try to return it to the incubator because it does like to autolyse. But we see those nice, pretty little kidney beans. But this is from a blood, and if it's not from a genital site, we have to do our confirmatory tests. So just like the song, it takes 2 to make a thing go right, out of sight. You have to, you're gonna notice the pairs throughout our presentation. You have to do 2 definitive methods for identification. So for identification, we used our Vitek MS MALDI and our Vitek NH identification card. And for the plate growth, you can kind of see there's growth on the MTM and the chocolate in the blood. So we have Neisseria gonorrhea. So some additional testing that was performed, they did a GC throat culture that was negative, a CTGC PCR testing. So it's negative as well, and also HIV and RPR were negative. So this kind of points to the fact that this is probably a past untreated case where it actually disseminated into the left joint and then actually disseminated into the bloodstream. So I'm going to hand off to Jennifer first to walk through some susceptibilities of what we did.
Okay, so we also did cephinase, and it was positive, and so therefore penicillin is resistant. Normally, you know, we don't do testing unless it's treatment failure or it's requested by the physician. And some primary agents are listed here: azithromycin, ceftriaxone, Cipro, and tetracycline. And there was a CLSI update 2021. And so showing here is the M100, and we're just showing, you know, if you do get a request, it takes special media. So most of the time this is a send out. So if you see here with ceftriaxone and azithromycin, that we only have susceptible interps. We don't have intermediate or resistant. And then in the 31st edition of the M100 for azithromycin, did add the disc diffusion.
Okay, and so as far as treatment and outcome, our patient was diagnosed with Neisseria gonorrhea septicemia. So after negative blood cultures, our patient was discharged on for treatment with ceftriaxone and azithromycin for 7 days. And then lately there has been a recommendation for treatment that we're using ceftriaxone, and instead of azithromycin, using doxycycline in cases where you can't quite rule out chlamydia. So with the theme of our presentation, more pairs, you often see co-infection there. So in cases where you can't exclude it, they're recommending that you actually include a doxycycline twice a day for 7 days. So a little bit about some Neisseria gonorrhea complications. Just like with our patient, we did see a disseminated infection. It's not seen as often. We also have low-grade fever, hemorrhagic lesions, and we also have joint involvement. So we have that septic arthritis. And for quite a few of the cases, you might not be able to recover it in culture. But we've had a couple cases at Baptist where we've been able to recover it. Okay, so the reason why we chose this case was we're starting to see more resistance show up in gonorrhea. It's CDC is estimating about 820,000 new cases of gonorrhea are being identified, and then it's actually the second most prominent infectious disease that's being diagnosed. So with that, Jennifer's going to walk us through the surveillance component that CDC is doing.
All right, so the gonococcal isolate surveillance project was established in 1986, and it involved participating STD clinics and military clinics. And for the first 25 men diagnosed with urethral gonorrhea, testing was submitted for resistance to primary drugs. And so then that we can monitor antimicrobial susceptibility trends. And you can see in this graph that there was resistance developing for fluoroquinolones. So that treatment was no longer recommended. And then this shows the need for continued monitoring for the emergence of resistance and treatment failures. Why it's so essential, because we have the primary agents here as well. And you can see that the MICs are climbing.
So with that, just like Captain Planet, with our powers combined, Jennifer and I were able to solve this case of Neisseria gonorrhea septicemia. So we'd like to thank the Jacksonville Microbiology Society, the membership, for having us. And
a special shout out to Dr. Valencia Shelton for mentoring us and helping us with our presentation.
And then we'd like to thank our Baptist Health Infectious Diagnostics team. And with that, we'll take any questions or discussion. And even if you guys know what some of the testing is at the top, you can kind of share if you remember what these things are.
If you have a question, check your mute button.
Oh, there it is. Okay.
So Beth said CTA sugars.
Thank you. I can see that. Go ahead.
Thank you, Erin and Jennifer. I just like to go back to just not that we like to call out our mistakes, but really touch on the corrected gram stain. Just from, there's other technologists on this call, and, I'm sure different technologists work different shifts and have over time. What are some things that you think led to this? Is it just such a complex or difficult gram stain to read? Or, do you believe that it had to do with additional support on the shift? Because you mentioned, 2 additional technologists to review the gram stain on first shift. Just what are y'all's thoughts for that from your perspective?
Do you want to go first? Okay, so for me, I'd probably say it's a difficult call. And just as far as the it's one aerobic bottle, it's it does help to have additional eyes, but and this picture is actually from a library of photos, so the tech could have seen like one field. And the other thing too is with the blood culture media, it has SPS in it, and it will inhibit like Neisseria meningitidis, like the aerobic bottle and the NGC in some organisms. So that might make me question it, but yeah, I would say the supportive day shift does help.
Yeah, because on that shift there was really nobody to help. Whereas, the tech reading it the next day, just could say, hey, can you please check this for me? And we also had the plates. So, we sort of had insight into what it was.
Yeah, hindsight is 2020, and I love that all the techs are supportive and said, yep, no one ever really wants to call a gram-negative Diplo. It's not commonly seen. Oh, I have a question here. When it is difficult to call on 1 gram stain, do you typically do a second, or do you wait for another bottle to go positive? So I think it's a great time to touch on some different techniques used in the laboratory when you're not sure of what to call it. But I don't think that was the issue here. I don't think it was, well, I don't know. I'll let y'all speak to that.
Well, I can speak on, when it's difficult to call, because if there's any question and there's nobody to really help support you, the best thing is just to call and notify, the patient's nurse or physician that the bottle is positive, but, we're having difficulty interpreting the gram stain, and just call it positive at that moment.
And with our, at least adapts to their sterile body fluid that we do, if it's something questionable, or if we actually do a second smear. So that is something that we do in our problem. Like if we're not sure about something, we do the second smear.
Right. And yeah, so also acridine orange is used in our laboratory, and something else was just that in this case that wasn't mentioned was there was a second reviewer. They were confident in the call at the end of the period, and so y'all can't hear me. Sorry. So yeah, no, it's a tough call. So I'll leave it be. I don't think there's any more questions. If there is, of course, please chime in.
Oh yeah, and if you do have any questions, get us to the very end. You can email Jennifer and I about the case, or if you have fun stories, or you can contact Dr. Shelton and relay it through her, and we can all talk about it. So.
One last comment from Ogechi was that she would leave it for leadership to review in the morning after reporting a positive. So it's another great technique that is used a lot of times as well.
Yeah, good suggestion, OG.
Yeah. Okay, very good. Well, thank you. Thanks to everyone, all the presenters, all great topics. This was really nice. A great job by everybody. I think everyone enjoyed going from seeing a variety of topics. We hope to do this again. So again, thank you for joining by Zoom or phone. Please watch your emails concerning the review and voting for the revised bylaws, and for details, as Beth mentioned earlier, about the September, hopefully in person or maybe a blended meeting. Before we sign out, I guess we still, probably Debbie's not on, but we again appreciate Promega and Debbie Hernandez for sponsoring tonight. And Amanda, our new president, you have any closing words for us?
Just that I'm really excited to see what this next season brings, and hopefully we can get back to seeing each other in person and having that wonderful interaction. So thank you Ray, for all your leadership this year.
Thank you. So everybody have a great summer, and stay safe, and we'll be in touch during the summer. Good night, everyone. Bye-bye.
Good night.
Thanks for having me.
Wave at our fearless leader.
Great job, guys.
Bye-bye.